All right, good deal. So we're going to kick off this week. This was coming out of week 3 for our PowerPoint review lecture. We talked about range of motion, specifically limitations or motion restrictions and how we address those restrictions from a therapeutic standpoint. So discussed a few things, but let's cap it off with the first PowerPoint that just has to do with motion restrictions in general and where they seem to come from. Come on, work for me. Okay, I guess that's what we're doing. There we go. All right, you know the learning objectives. So we know that you have normal range of motion when the body is functioning normally. That makes sense, right? When you have a motion restriction, it's going to contribute the. It's like, why are we worried about motion restriction? Well, it limits the functional capabilities of our patients and can manifest in terms of disability, right? So it can also lead to further pathology. So, in order to restore motion, make sure that you know that we have to understand the normal motion, so know your normal ranges. Go back and review all those. You have to assess the motion restriction, figure out, okay, what's causing this restriction? We talked about that in class. And then you have to choose the right treatments that are going to optimize the patient function. So, what is the patient capable of doing? Where are the restrictions located, not just numerically in terms of goniometric value, but also like what structures are they, interarticular, extra-articular, and then comparing those to the normal motions to figure out, okay, where do we need to go from here? Active range of motion, know the definition here for sure for your quiz. This is produced by contraction of the muscles that cross a joint and is normally less than passive range of motion. Make sure that you pay special attention to what can cause active range of motion restrictions, right? So we talked about this. Different types of range of motion can have different onsets or different pathologies that are associated with them, so they give us clues about what might be going wrong. Active range of motion has a contractile component to it, so it can be restricted by something like muscle weakness or abnormal muscle tone, which we talked about last week, and for sure pain, and the fact that you could just be limited passively, right? So that gives us, you see a patient with active range of motion restriction, you're like, could be one of those things. Passive range of motion is produced entirely by an external force without any voluntary muscle contraction. So there's no contraction whatsoever. An external force, like a therapist or a mechanical piece of equipment, is going to produce the force necessary to drive the range of motion. So with this, we're going to be restricted. Potentially, there's soft tissue shortening. There could be swelling in or around the joint, adhesions, which are essentially just sticking points within the soft tissue or surrounding tissue, connective tissue, mechanical blocks, like maybe a bone spur or something like that, disc herniation, or a neural tension issue. So what we're seeing here is we don't see any contractile mechanisms here where we did with active range of motion. That's because in order to elicit a passive range of motion response or movement, there is no contractility. So here are some examples of end feels, right? Each one of these. This would be a firm end feel if we come into dorsiflexion because we've got the tightness from the Achilles tendon or the tendinous restriction that's producing the firm end feel. Here's a soft tissue approximation where the muscle is approximating or soft tissue is approximating to other soft tissue, and a bony or a hard end feel, which is bone to bone. There's the olecranon process of the ulna into the olecranon fossa of the humerus. So you guys know that. Understand that the definitions between physiological and accessory motion. So physiological motion is the movement of a body segment relative to another segment. Accessory motion describes the joint play, and this can be interarticular or extraarticular, meaning inside or outside the joint. And this is a necessary component of creating physiological, normal, active, or passive range of motion. And this is where we have our concave and convex movements. So you guys should know this by now. There's an example again. We have a concave surface of the tibia moving in an open chain position against the convex surface of the femoral condyle. All right, so in this example, concave on convex, we have the roll and the slide occurring in the same direction. Go back and review those if you can't remember. That would be an interarticular, right? This is happening within the joint itself. It has to do with the two approximating joint surfaces inside the joint capsule, right? Outside the joint capsule, from a macro perspective, you know that you have a force couple that engages in something like shoulder flexion or abduction, right? So we need to have a certain amount, a sort of 2-to-1 ratio of glenohumeral movement that's accompanied by scapulothoracic movement in terms of upward rotation of the scapula. Right? So that's an extra-articular accessory motion. Capsular patterns, know the definition. I will give you the list. I'll put the list out there on your supplemental materials, but know the list here. Like, what is a capsular pattern? Well, it's a pattern of motion loss caused by shortening of the joint capsule. So it's a motion loss that's going to have specifically to do with the intra-articular structure of the joint capsule. So it's going to restrict motions in multiple directions, and each joint will have sort of a unique fingerprint of patterns that are going to be most restricted depending on the makeup of that joint. So it could just happen that, be the fact that you maybe have some adhesion within the capsule. You could have effusion, which would be swelling within the capsule, a certain level of fibrosis, which is like a excessive laying down of fibrous connective tissue, or inflammation. All those things can cause restrictions in the joint capsule. And these are associated with things like DJD, arthritis, immobilization, and trauma. So here you go. Here's a joint capsule, right? This example, we talked about the axillary folds, how they sort of unwind like an accordion to allow for the mobility necessary from the inferior component to give that range of motion, that freedom of mobility to the humerus and the head of the humerus to be able to roll and slide in a direction that will create flexion or overhead activities. If that goes away and you have a shortening of that joint capsule, when I go to raise this arm up away from my body, it's going to correspond to a tightness. It'll run out of slack, so to speak, and that can limit my ability to reach up overhead. So that would be a capsular issue caused by a capsular pattern, and abduction is a huge part of the capsular pattern in the shoulder, and also internal-external rotation. All right. Obviously, not everything is capsular, right? So you have patterns of motion that don't follow a capsular pattern. Please just understand that you could have capsular components, which would be a capsular pattern, or there's ligamentous adhesion, right? Ligaments add stability to the joints, but if they stick or they become too rigid, they can limit range of motion in directions that stretch the adhesion. Internal derangement would be like things like menisci or things inside the joint that are deranged or to some degree have been impacted negatively. And they're limiting range of motion. And then extra-articular lesions are going to limit the range of motion. These would be things like, could be other tissues surrounding the joint, could be like muscular damage, could be soft tissue damage, integumentary damage. Those can also limit range of motion. So just remembering that there's different types of tissue that can contribute to restriction of motion. Contractile tissue, which is always going to be related to the muscle, the muscular-tendinous junction, the tendon itself, or the bony interface between the tendon and the bone itself. So dysfunction can pretty much limit active range of motion and may result in pain or weakness because it is impacting the contractile nature of the tissue, right? It's the muscle tissue. Non-contractile tissues tend to be things like skin, fascia, ligament, bursa, capsule, some of the things we talked about. Those dysfunctions may tend to limit passive range of motion, but they won't have a contractile component, right? So if you have a issue with the skin or the fascia or the ligament, bursa, capsule, it's unlikely that you're going to have active range of motion. Let me flip that around. It is likely that you're going to have passive range of motion restrictions, and you may or may not have associated active range of motion restrictions, right? If these are impacted, you probably will, if you don't have the available passive range of motion, you probably will have some degree of active range of motion limitation, not because the muscle is weak, but because you can't actively move what you can't move passively. Okay, sorry, I screwed that up for a second, but we'll backtrack. The other side of this is an active range of motion limitation. If I'm limited actively, it could be just because I have some muscular component or pathology that's limiting me into my movement, right? So I could be just weak, and because of my weakness, I might be limited in active range of motion, but there's no problem with any of these non-contractile tissues. So actively, I can't lift the arm, but passively, if the therapist comes in, they can take me to a greater range of motion because there's no problem with any of these things. So they play off each other. All right, we discussed contractures a little bit. Just know the places how we categorized contractures, we'll talk about that in a second, usually caused by immobilization, worsened by scarring or cross fiber linking, can be caused by any one of these. Here's edema. We can have edema inside the capsule, intra-articular, inside the joint or around the capsule, or around the joint itself, which is extra-articular fluid, which would be presenting as a non-capsular restriction. Adhesions can be caused by scarring, just immobilization, disuse. Mechanical block would be like an osteophyte or bone spur formation, or just cartilage fragments that are inside the joint itself. Spinal disc herniation usually is going to be caused by pain of the nerve root compression. Can't really see it here, but this is osteophyte. They just have like these little bone spurs in and around the area of that carpometacarpal joint. All right, there's pathologies that can lead to motion restriction. So just to have a healthy understanding of this, more weakness, again, that's going to be limited to mostly active range of motion. Adverse neural tension, again, nerves need to be able to stretch too. When they can't stretch or they have an abnormal response to the stretch, they put pressure on the nerve in a way it doesn't like, so it can cause pain and restriction. Other factors, sometimes psychological pain and muscle tone. All right, examination and evaluation. So we have to, obviously, part of our, not within our purview necessarily of PTAs, but what you'll see from the PT and what will be reassessed regularly is going to be the mobility of all the structures in the area of restrictions. So we got to test those things, figure out where they're at. Got to evaluate them and say, okay, we have to be accurate. Like, what exactly is going on? Are we talking capsular pattern? Are we talking non-capsular? Are we thinking this is a contractile tissue issue, or is this a non-contractile tissue issue? So your PT will give you insight for that. Evaluation needs to constantly change as things go on. That's why the PT will hand down the evaluation. They come back to you. They say, all right, go ahead and do this, that, and the other thing. You devise the intervention protocol. You do that for a week or 2 weeks, whatever. Then we go back into a reassessment, reevaluation sort of phase of the process. And we use both quantitative and qualitative techniques, which we've talked about before. So quantitative measures are going to be numerical measurements. These are like the angles between body segments, something that's going to give us a hard and fast number, right? The patient has 162 degrees of shoulder flexion. Inclinometer is another way of measuring. Electrogoniometer is just a different mechanism for measuring goniometric measurements for range of motion. And then also have the length of the girth of a body segment. So is there a leg length discrepancy? Well, we'll measure with the tape measure. Is the left leg bigger in the calf than the other leg? We're going to use girth measurements. You can also use x-rays, pictures, flexometers, which is like the old-fashioned V-sit, and plumb lines against a scale on a wall to give you better insight. Qualitative, this was more about like just sort of gathering subjective information, more or less. So using our hands to assess soft tissue, feeling like, okay, this feels stiff here, or it's tender there, or, ooh, yeah, it hurts when you push on this, or there's active inflammation. Also accessory motion testing. What does the roll and slide feel like, right? Is it moving right? Is it clunky? What's up with that? And the end feels here. So hard, firm, soft, empty, spasm, spot. We've talked about end field before. We discussed that. So here's how you can consider testing active range of motion. We know that we can manual muscle test for sure. We can interpret the resisted muscle testing based on the amount of force and presence of pain with that force. You can also look at the quality of the motion. Is it symmetrical left to right? Is it normal? Is it excessive? Then what are the signs and symptoms? Does it hurt? Is there a compensation pattern? With passive range of motion, what we're looking about is really the amount of passive mobility available and the end feels that could be pathological or physiological. So pathological end feels are end feels that are abnormal, that are associated with a certain pathology that's ongoing within the joint. So if I get an empty end feel, could be empty because I didn't achieve the end feel because I had too much pain or the patient had too much pain, right? Or if you have like a springy block, right, there could be like a meniscus tear, some kind of interarticular damage that's restricting the end feel, makes it feel abnormal. Physiological is just a normal depending on the components of the joint, right? Soft, firm, hard. There's your passive accessory motion too, measuring the extensibility of the major ligaments, right? Doing ligamentous testing to see if there's hyperlaxity or hypolaxity, measuring the or feeling for the available movement of the joint capsule, how long the muscle lengthening, right, available to you. So measuring the excursion of the muscle, and then doing adverse neural testing, which you can see we've done some tests before that have to do with neural tension, like our passive SLR test, bending the knee in prone, the Lhermitte sign, right? So you guys know these. Motion, active or passive motions can limit adhesions, right? So this is how we're going to treat our motion restrictions. How do you treat a motion restriction? Well, you move the thing, right? You move it. So we're going to do range of motion, which is just one thing we'll talk about moving forward. We'll also implement stretching patterns, right? Passive stretching, we can use PNF like we've seen before, and I showed you in lab, or ballistic stretching, or surgery might be needed if you've got like something, a bony mechanical block like a bone spur that we're not going to be able to impact, or just contractures are not responding to treatment. So obviously, as we go through the course of this class, restoration of range of motion is going to be an important treatment outcome for our patients in general, but we're also going to be able to use physical agents, right? So you don't want to rely on physical agents by themselves to prevent motion restrictions. A lot of the manual stuff we're going to do, like the exercise, it's sort of a collaborative effort of tools in your toolbox. But you can use physical agents to increase soft tissue extensibility, control inflammation that could be inside or around the joint that's leading to restriction, find ways to control pain through gait control theory, facilitating motion. So those are the big takeaways from the first one. These are where range of motion comes from. For purposes of your quiz, we should look at differences between active and passive range of motion, types of end feels, difference between physiological motion and accessory motion, basics of concave convex rules, what is a capsular pattern, differences between contractile and non-contractile tissues, what is a contracture, what does it mean when I say intra-articular versus extra-articular? What are the things I could be talking about? Just the certain pathologies, just a general understanding of those pathologies. When you might see one in contractile tissue versus one in non-contractile tissue. The importance of evaluation, differences between quantitative and qualitative measures we use for range of motion restriction, how we can test for it, how we treat it, right? How physical agents can impact it. That's it. All right. Very good. We'll keep it moving on to the next one, but that is going to wrap us up for motion restriction for your review. So I'll see you in the next PowerPoint.